Welcome to the Clinical Pre-Hospital Care Research Forum Journal Club. Here in our PCRF Journal Club, we promote evidence-based practices by critically evaluating the latest science in emergency medical services. We hope our discussion will help advance EMS practice. Through the generous support of our sponsors, Limmer Education and ESO, we are able to make science more accessible and understandable.
Good morning and welcome to the Pre-Hospital Care Research Forum. This is our 2026 Journal Club for the month of June. We're happy to be reviewing the pre-hospital whole blood and traumatic hemorrhage, a randomized control trial. And I say we, but there's a decent chance it might just be me today. We're enjoying some of our panelists are enjoying a vacation or off doing a research workshop in Texas. So we may have some folks jumping on, but otherwise you may be stuck with me today. We're taking a deep dive into this article because you cannot attend a conference, you cannot open an EMS news website or magazine without hearing something about the use of blood in the pre-hospital setting. We have over 200 agencies across the United States that are either in the planning phase or that have rolled out and are administering blood in the pre-hospital setting. It seems like you don't have to go very far to hear blood, 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 blood in the pre-hospital setting. The benefit of that is we're getting a whole lot of data that's analyzing whether or not blood in the pre-hospital setting is effective and which patient populations it's most effective in. And that's really why we picked this article to start things off. This article really does a deep dive into what they consider the standard of care, which we'll get into here in just a minute, versus the administration of whole blood. And this is an article that comes to us from the UK, which is really quite interesting because it's going to look at some physician-driven data and it's going to look at some of the air ambulance data that they have pulling out there. But it's really meant to give us a nice solid foundation for understanding blood and blood component therapy in the pre-hospital setting so that we can continue the deep dive that we're going to do in a couple more months with a couple of the research papers that are coming out or that have just recently been published. There was a good one that was just recently published this month that looked at blood product and blood administration for the Department of Defense. So we've got some interesting things coming up, and so this sort of sets the stage for us. As a reminder, all of our articles are paired with or all of the podcasts are paired with an article that'll show up in EMS World magazine. In fact, I just wrote the one that we did last month on Tanner Smeda's cardiac arrest paper. So that'll be out in the next edition of the EMS World magazine, and those can also be found online for EMS World under the Journal Watch. Again, we're diving into the pre-hospital whole blood and traumatic hemorrhage, a randomized control trial. This comes to us from the UK, and again, really doesn't sort of sets the foundation for us as we start to look at whole blood administration in the pre-hospital setting. And in the US, a lot of our treatment, at least on the ground, is the delivery of whole blood versus the delivery of maybe normal saline or lactated ringers. We don't have a lot of pre-hospital agencies that are doing what this article looks at, which is why we pulled an article from Europe when it's a really good study and it was published in the New England Journal of Medicine. So it's got a really high impact factor. Lots of people are seeing it. There's lots and lots of discussion around it. But they're going to do a bit of a deep dive into whether they're looking at whole blood transfusion. So that would be the red blood cells that we like. You took it from the patient, you're giving everything back to the patient, is the way I like to think of it, versus what they're going to describe as a standard of care administration, which is up to 2 units of red cells and plasma. So they've taken the blood from the donor and sort of washed it out, or at least pulled the constituents out of it, which would be the red blood cells and the plasma, and then they're administering that back to the patient. Now, you might be asking yourself, why would we pick those? Why would they be doing those things rather than just giving whole blood? And a lot of it has to do with logistics and storage. It's much easier to store the red blood cells in the plasma Sometimes you can do this frozen, sometimes you can do this at room temperature, just depending on how it's packaged and how it's preserved. But it makes it a lot easier from a logistical standpoint than giving the whole blood, which has an expiration date, oftentimes has to be kept at a certain temperature. If those temperatures aren't maintained, then the blood is no good. Same thing, it reduces some of the waste because we can store it longer, we can use it longer logistically. That means there's a higher chance that that pre-hospital administration is going to occur and those packed red blood cells are going to get used up. So there's a lot of questions that are really still out there around what is the most ideal way to be administering whole blood in the pre-hospital setting. And I see some folks in the chat that are working for agencies that do in fact give whole blood, and they will probably more than happily share some of their logistical challenges that come with administering whole blood in the pre-hospital setting because it's not an easy thing to try and manage. Many of the folks that are out there will probably say they can pull up the temperatures of all of their coolers on their phone because that storage is such a big deal. So anyway, very, very important and why this sets the foundation for us. And Jeremy did a nice job. The two war study is the one I was referencing that was just published by the Department of War. That's really interesting and probably the one that we will do as we sort of dive into blood products across the board. So thank you for sharing that. Also published in the Western Journal or the New England Journal of Medicine. So let's dive into the methods for this one because again, we've got a whole bunch of results and they've done a really nice job of putting these into a table, but I think we should dive into how they designed this study. And the first sentence of their methods is always a nice one to sort of give you the overview of the study. So I'm literally just going to say they conducted first what they called the SWIFT trial. So if you hear the SWIFT trial, this is this paper. It's the study of whole blood and frontline trauma. That's what SWIFT stands for. And they called this study a pragmatic phase 3 multicenter unblinded randomized control superiority trial involving trauma patients with life-threatening bleeding across 10 air ambulance services. So what does that mean? Well, pragmatic means they're trying to replicate what's happening in the real world environment. This isn't a laboratory study. This is actually what's going on in the real world. It's a multi-center trial. Again, they're using 10 different air ambulances to deliver this, which is helpful, again, at making it pragmatic. But also, again, we want data from lots of different agencies to help give us the results so that we can look at them in aggregate and help describe whether or not it didn't just work for my patients, it didn't just work for your patients, but it worked for all the patients in the trial. It was randomized, and I think they said it was unblinded and randomized. And the methods do a really nice job of explaining what this means to us. Obviously, when the provider is giving the medication, or in this case, the blood, they're going to very clearly know what it is, right? One, they have to document the intervention, so we can't hide from them what they're giving. But it was randomized in that they created these sealed boxes that either had the whole blood or had what they call the standard care. And they were sealed, so you couldn't open them. You didn't know what was going to be in it. And then they randomized who was going to be given it. They put you sort of got which box you were supposed to administer based on the trip that you were on, as they describe this very nicely in the methods. And then they opened the box, and once the box is open, that's what they're going to give. And that was the way they randomized this. So the provider didn't know what they were going to be giving until they unsealed the box to administer the blood. So kind of a nice way of going about doing this. That's how we say it's unblinded and still randomized. Again, the person administering it's going to know what it is as soon as they open the box. And it would be quite difficult in this sort of study phase to try and blind this from the provider. Again, we see this a lot of the time when we give certain medications. One, the provider may need to know what the medication is, but two, the packaging is different. The way we administer it may be different. So the provider is going to be unblinded once they open the box and they know it is. But this is a very solid way of randomizing a study to look at this type of thing. So again, it was across any patients involving trauma. So when we get to our exclusion criteria, we're going to find out that they excluded medical patients, at least for the initial analysis. And then it was patients that had life-threatening bleeding. So we're looking at patients that we can verify some sort of hemorrhage in. This is important because that seems to be where most of our pre-hospital blood in the US is being given. At least in the pre-hospital setting, our air ambulance colleagues are probably giving it, and there's a lot of data that supports them giving it in medical patients. But for the most part, in the pre-hospital setting, we're seeing a lot more given for traumatic injuries. And so this study fits that analysis quite well. Their patient population, again, was this whole blood group. They got up to 2 units of whole blood versus the standard care. And this was based on clinician judgment, and I was going to read this directly, and the standard criteria for initiation of blood transfusion for each air ambulance service. Now, the benefit to this is they gave us the supplement. So they gave us the criteria that they gave. And actually, these criteria fit very similar to what we're seeing given in the pre-hospital setting in the US. Much of the blood giving in the pre-hospital setting here in the US is dictated around a patient who's experiencing some sort of decompensating shock. So we would expect them to be tachycardic and we would expect them to be hypovolemic or hypotensive. So those things sort of match quite nicely. There are some other parameters that we see in the US, but this study did a nice job of describing across all 10 ambulance agencies the consistency between who they administered blood to. So we like that. Patients were excluded if they couldn't get IV or IO access. That probably makes sense. And they had or if the patient had a known objection to transfusion. And I think that's an important consideration that we see taken in this study that we oftentimes see taken in the pre-hospital setting. I think sometimes we worry about giving a whole blood administration to an unconscious patient. We know that we can, but I think there is that concern about what is the objection rate to receiving whole blood. And we see some of the US studies that do tend to look at that to see what rate that is. Obviously, if there's a lot of people that are objecting to this medication, that should be taken into account for how we administer it. So they did include that in their exclusion criteria, which I thought was really, really helpful and sort of gave us some analysis of where we're going to go for that. So that was our goal here. The trial boxes contained only blood products carried by most of the ambulance services. So they note that, again, it's unlikely that every service would look exactly the same and would use the same tubing and things like that. But they worked really hard to try and randomize that in their inclusion criteria. So we like that. The last thing, and I thought was important when they talked about the randomization of this, we hit on a little bit of it, but they did assign the boxes, whether it was the standard or the whole blood group, in a 1-to-1 ratio. So we'll see if we get there in our methods, but the goal being that eventually, if we assign it in a 1-to-1 ratio, that we would get sort of similar results in terms of the number of patients that received each treatment. That's an important component that we care about. And we'll see some of that become a little bit more difficult when we look at our US studies, simply because if we're just giving the product versus not giving the product, or everyone's getting the product, it can become difficult to, again, randomize that. We typically don't design studies where we don't give somebody something that we know could benefit or be life-saving. So it'll be very interesting to see how they account for that in some of the US studies. There are ways to do that, and there are some mathematical ways you can do that. We can always look retrospectively, but if you're going to do a prospective trial, then you have to account for some of those things. So they did a nice job of accounting for that, so we like that. That gets us to our outcomes and what they were looking for their results. So their outcome was a composite of death from any cause from massive transfusion defined as 10 or more units. So there's a chance these patients are going to likely get more blood once they get to the hospital. In adults, so they did, we'll see in the results, they actually did look at some people under the age of 18, but they're very interesting that how they looked at this. So we'll get there. But primary outcome was a composite of death from any cause or massive transfusion. So we're going to look to see, and this is a superiority study, so we're going to look to see if if some of the groups of patients had a higher outcome or survival than others. And important to note that they looked at within 24 hours. Now, we're going to see they have a whole bunch of secondary outcomes, and we're just going to go line by line through the table to look at that. But they have some secondary outcomes that look at things like 6 hours, 24 hours, and 30 days. Always really interesting, and most of the blood studies do look at long-term mortality as well. It's very similar to the cardiac arrest data that we consider. It's not just getting them to the hospital with a pulse, but were they able to walk out of the hospital neurologically intact? And again, ratios for all of those things. So there's a whole paragraph and a half of secondary outcomes, but their table does a very nice job of explaining that to us. So we're going to take a look at that here in just a minute. So with that, I think let's get into their analysis and their inclusion of patients, because they do a really nice job of dictating this to us in this very nice flowchart about who was included. So they had almost 1,000 patients in this time period to look at. So again, really, really nice. They had already randomized them. So that was nice. So some of these patients are in the standard group. Remember, that's the patients getting the red blood cells in the plasma and our whole blood group. So you can see here in the first box, they had their about half of each were assigned. So they had 470 that were assigned initially to whole blood and 472 assigned to the standard care group. So good, that one-to-one randomization that we talked about is working. So very helpful for us. Um, Again, 436 from one group received the intervention and 432 received it. They do tell us why they didn't give it. So a couple were withdrawn or data was removed at the patient's request or the request of for some reason. And so we see that. And then some of them did not receive the assigned intervention. This can happen. Some patients don't always, sometimes they don't always follow the study parameters exactly, and so those things are oftentimes excluded. We don't exactly know what all of these can be, but one of the very common reasons someone in a blood group might be excluded is they received the treatment, but it wasn't necessarily indicated for them. So perhaps we administered the blood, but the patient didn't meet the indications or follow the protocol strictly for that indication. And you see this done, I shouldn't say it's not common, but you do see this done occasionally in the pre-hospital setting, even in the US, where a patient who looks like they might be a quality candidate for blood gets it, but they don't meet the inclusion criteria, so we don't include them in the study. So this makes sense. And again, we see a nice, very similar rate of who's in each group and that we're including a similar amount of people in each group. So far, we're very, very happy. When we continue down, we see 143 were excluded, and then they removed a few patients who didn't meet our inclusion criteria. So these would be patients that did not have a traumatic hemorrhage. So maybe they had a non-traumatic hemorrhage. They also excluded cardiac arrest for the primary analysis, which they do note in their methods as rationales that those patients have a lower chance of survival, and that makes sense. The traumatic out-of-hospital cardiac arrest survival rate is very, very low. So to prevent those patients from skewing our data in either direction, they removed those patients. So they had a few that had some data withheld, and again, not uncommon. But again, we're really looking for the patients who will benefit the most from the treatment, and that's why we excluded some of these populations. Then we come down to the next line where we've got 327 who were included from one group and 314 from the standard group. So again, pretty similar across the board, which we like. They then looked at how many patients died within 24 hours, and they tell us here how many died within 24 hours, as well as how many died on scene. And the numbers here very similar across the board. So this should help us form an opinion of whether or not the two patient populations are similar. They did everything they could in their scene or in their I was going to say scene size up, but in their study size up, I suppose you could say, to make sure that these things were similar. And again, that's why we're seeing these similar numbers. This should give us more confidence when we see these numbers being similar in the results. So then they looked at how many, again, made it through 24 hours of the trial period. So that's good because that's our primary outcome. And then they had a few patients who were withdrawn before the 30 days. So they're not going to be included in the 30-day analysis. So they had some patients that were withdrawn, some patients who passed away, and then they lost some follow-up on some patients. And again, that's not uncommon either. We see this in all kinds of studies when we look at medication administration, even in cardiac arrest data. Some patients, we just don't have the linkage of their data, or we've lost the follow-up with that patient, so they're not included. Then we get down to about 210 versus 219 patients completed the 30-day trial, so we can include them in that data analysis. And then they went to 90 days again, because we're going to look farther out to see how the patients did. And they had a few more where they were either withdrawn or they lost follow-up or they passed away. So that gets us to 210 to 205 that can be included in the 90-day analysis. Again, very similar numbers. So this is telling us that our patient populations are pretty consistent across the board. And again, even if our results are different, that's okay. What it's telling us is the patient population is very similar, and those are the things that we want to see to give us the credence that our results actually do make a difference. Obviously, this was published in the New England Journal of Medicine, so this should give us some incident that this is a good study that we care about the results in, but as a little bit of background, those are the things that we're looking for. Now, we always go to table one. before we dive into the results. And this again is important too. We want to make sure that we're comparing, and in this case, it's people, but oftentimes we use the analogy apples to apples. But if you listen to Remley, she'll tell you that we want to be making sure we're comparing the Granny Smith apples to the Granny Smith apples. So we want to make sure that we're comparing similar patients to similar patients. And these numbers did bear out. So again, we're looking at that whole blood group versus the standard care group. 327 in the whole blood group and 314 in the standard care group. We like that. The median age was 38 and 35. So very interesting that this is a younger patient population than probably we're used to looking at. Usually we look at a little bit older population, especially when we look at things like cardiac arrest data. But these are patients that were involved in trauma, and we oftentimes see that skew to a younger population, and we see that skew more towards men. So we'll see if that bears out here, but certainly we did see that it's skewed to a younger population. That's good. They're the similar ages, so we'll take it. They did look at ages under the age of 16. So again, I said that they put their adults into their primary assessment, but they did look at other populations as well. And so they have about 3% of their population or so, between 3 and 4% of the population that was under the age of 16. And then male sex continued with our trauma data, which is men are more likely to be involved in trauma or get themselves into more trauma, however you want to look at that one. About 75% of the patient population was men. And then the average weight, because some of their secondary analysis and their safety outcomes were based on weight and the blood resuscitation based on weight. So that was the same across the type. Very similar was the injury type, blunt versus penetrating trauma. So those numbers across the board, which who got each group is fine. They did do an injury score, and they talk a little bit about that in their methods. It's an abbreviated score, so they did some assessment on it. But what we care about is that the numbers are pretty consistent across the board, and that's what we see. So we're happy with that. What probably means a little bit more for those of us in the pre-hospital setting are the systolic blood pressure and the heart rate, because oftentimes that's what dictates our intervention in the pre-hospital setting. And so here they had the mean systolic blood pressure was 95. So again, we're looking at patients that are in a hypotensive state or headed in a hypotensive state. The mean heart rate was 110 across the board. Again, those inclusion criteria oftentimes in the US are patients suffering from tachycardia. So that sort of fits what we might be looking at if we're looking at using this study to support whole blood in the pre-hospital setting in the US. Respiratory rate, a little bit of tachypnea, and an oxygen saturation of 94, 95. Now, I was looking at all of these results and I thought it was very interesting that the respiratory rate makes sense to me. The heart rate makes sense to me. The blood pressure makes sense to me. Their pulse oxes were pretty good. So I thought that was kind of interesting. Sometimes we think of our shock patients maybe being a little bit clamped down peripherally, and that means that their oxygen saturation may be low to their fingers and toes where we measure those pulse oxes, just simply because they're in a decompensating state. But they had some good oxygen saturation. So I think, again, that should make us even more confident in our end results that they're picking patients that had opportunities to survive. So we like that. It also means that, again, they met their pretty standard treatment protocols for blood. So most of these are falling within a range where we would be like, yeah, that's similar to what we would give for blood in the US. And then they looked at the GCS scale and they stratified for that. And again, those numbers are pretty consistent across the board with the average GCS being 12. So again, if we're looking at this in the pre-hospital setting and we're looking at administering whole blood, this is a great study to give you some parameters around what those mean numbers are, what those averages are. And a mean GCS or an average GCS of 12 tells us that the patient may have some inability to make decisions. So if we're trying to consent people before blood administration, or if we're doing training to consent people on how we do that by our pre-hospital providers, it's worth noting that the patient may have some altered mental status, and that should probably help give us some parameters and some direction about who we're consenting into our groups. Like, again, implied consent, it works great, but if you're thinking, hey, we need to consent everybody before we give drugs, because there are those patients that will object to blood notification, that may not be a feasible way to set up a study, because again, our patient may show some altered mental status. So. And then here is the sort of just a continuation of table one. And they looked here at the pre-hospital treatment characteristics, so other things that the patients received besides the standard of care or the whole blood. And you see that about half the patients got some airway support and some breathing support. So probably not uncommon to what we would think of for a patient receiving blood, especially with a decreasing blood pressure and a decreasing Glasgow Coma score. They did look at about a quarter of the patients got a thoracostomy. of 40 to 43% of the patients got some spinal immobilization. A small percentage of the patients got a chest drain, and then they defined others, a whole bunch of other procedures. So very interesting to see how much what the other interventions were for our patients. But I think it does sort of go to a frame of mind that these patients are sick. If half of them are getting airway support and half of them are getting breathing support and a quarter of them are getting their thoracostomy, I think those things go to tell us that, yeah, these patients likely had some more substantial injuries. We certainly don't want to assume too much on the injury patterns of our patients because we're going to get some of that in our results. But if you think thoracostomy, breathing support, airway support, we're probably looking at some patients who had some chest injuries, whether that's blunt or penetrating. We likely did. So that's interesting. The mean age of blood transfused, they tell you here too. So that's kind of interesting, especially if you're thinking about doing a blood program in the pre-hospital setting. Somewhere between 2 and 3 weeks is what is the age of the blood that they saw here. So I thought that was kind of interesting. If you're thinking, well, how often are we going to need to give blood? I think do keep in mind in the pre-hospital setting that may vary a little bit, just based on the fact that this study was air ambulances. But worth noting that it is kind of interesting when we see that. And most studies that we see on blood administration do track that information. So again, if you're setting up your own blood program, that's something to keep in mind and to consider because we do have that. And then drum roll, we have our results. And our results, this is the primary outcome. So this is death or massive transfusion within 24 hours. So the patient either succumbed to their injuries or it took more than 10 units of blood to resuscitate the patient. And again, that massive transfusion sort of definition is used in quite a lot of studies. If you think all the way back to even when we were doing analysis of TXA, that massive transfusion protocol came up several times when we were looking at those studies that really validated TXA and looked at not just patients that got blood, but patients that then received a massive transfusion. So that helps us define this study a little bit more as we're looking for patients who sort of got 2 units in the pre-hospital setting, but then didn't receive more than 10 throughout the duration of their study. So those patients are oftentimes put in another group when we talk about massive transfusion. So worth noting that that's in here. So, and then you can see they did modify the intention to treat population, and their p-value was 0.84, which tells us that there was no significant difference between the two groups. Now, the authors do a really nice job of going through this, and that's what we're going to do. I think this is the easy primary takeaway is that the standard of care group and the whole blood group did not have any difference in survivability or who got the massive transfusion protocol. There are lots more to this study in their secondary analysis, but I think worth pausing here for just a moment to say, while this doesn't necessarily reflect exactly what's being done in most of the pre-hospital settings in the US, this gives us a really nice foundation to say, hey, there's actually an easier way to give blood when we look at the standard of care, this plasma and these packed cells. And actually, that might be an easier way, at least logistically and storage-wise, to give blood. And at least this study found that there was no survival benefit to getting the whole blood rather than the standard of care. And if you're asking Michael Caduce's opinion, I think that's why this study is getting a lot of publicity right now, is it's demonstrating to us that there is some variability here, that we may not know everything there is to know about blood in the pre-hospital setting, and that it's probably worth considering some of these other ways of administering whole blood rather than we took it from the patient, we're going to put it in a cooler and we're going to test it, do all the things, but then we're going to give it to a patient. Is maybe there's some opportunity here to benefit our patients. So very interesting discussion as we go down into some of the other parameters, but from a survival benefit, they did not see a big difference or any difference is statistically significant in our patients who received the whole blood versus the patients who received the standard of care, which was their packed cells and their plasma. Now, they again go through a few different things and report out some other results here. And some of these things are going to start to become important to us. And so I've tried to highlight a few that I thought were important for our outcomes and some that are reflective to what we're seeing being done in the US. But we've got some pretty smart people in the chat who are running whole blood programs. So welcome you to put into the chat what your thoughts are on some of these things, have some conversations around it. So again, a couple that I thought were interesting just because we talked about massive transfusion and because that's something that shows up in other literature as well. We can see that they had no significant difference in treatment difference with those patients who ended up receiving a massive transfusion in the hospital. It's always just interesting. We really consider those groups of people different in the physiology and the response to massive transfusions than patients who just receive less than 10 units or 2 to 10 units in the pre-hospital setting. So I thought that was worth noting because we do usually classify those groups as different. You can also look here at our patients after 30 days and after 90 days of randomization. If we go all the way over here, we see that our confidence intervals all include 1 or past 1. They go over top of 1, so that means there's no big significant difference there. So we care about those things. And again, that's telling us that, again, this component therapy is working for our patient population that they included. So I thought that was interesting just because it makes it in there in a lot of the US studies that we see done as well. So there's a few other things. They looked at the PTT times and things like that. We're going to look at a safety profile here in one of the next tables. So I don't want to go too deeply into that, but they do talk a little bit about that. The majority of the rest of the things that they looked at here did not all crossed 1, so we don't see a big difference in that. So I thought that was worth noting that we don't see a lot of statistical significance here, and whether or not we see clinical difference, but statistical significance we don't see here. So. The safety outcomes, I think, is really interesting, especially as we look at is there one that's better than the other, at least based on one study. And so they did look at serious adverse events and they list those in the study. So if you're interested in what those criteria are, they do list them out. The whole blood group had 31 total events and the standard group had 37. So they did look at, are we having a change in outcomes for those patients? So really interesting there. Patients with 1 or more serious adverse events, they also tracked as well, and we saw a pretty consistent rate between the two. And then they looked at transfusion association adverse events reported to the group that collects these in Europe, which is they've noted here. So patients with more than one event or 1 or more events, they note here. And again, we see 0 in the whole blood group and 1 in the standard group. And these are ones, again, that we would consider having to be reported. They did look for thrombolytic events within the 30 days post-randomization. And again, those groups were the same. We had 17 thrombolytic events. I'm sorry, we had 17 pulmonary embolisms in one group and the same for the standard group. So no big difference there. In terms of DVT, we see 13 versus 11. In terms of myocardial infarction, we see 0 versus 1. Stroke, 6 versus 7. And then when we had some sort of ischemia that led to tissue damage, 1 versus 2. So again, I think it is worth looking at what the outcomes were, what the serious adverse events from a safety profile are. But they show us these and then they give us sort of the totals and what they are as a percentage. And the big deal is that we're seeing that they're pretty consistent from one to the other, which is telling us that their results at least are telling us it's fairly safe. So worth noting here again as we continue to have the conversation about whole blood, one of the very common things that comes up is it safe compared to what the standard care is, at least in Europe? But there's other agencies that have been doing this, especially when we look at some of the military. So very worth noting here, and we like that. Those are our safety adverse. So those are our safety outcomes. And again, the authors do a really nice job of going into their discussion and extrapolating that, at least in their study, we don't see a difference in the patients who were received what they consider their standard of care versus those who received their whole blood, at least 2 units of blood. So I think that's worth noting and why this study is getting a lot of publicity and a lot of conversation. I think patient population wise, they looked at a very similar group of people who received both from a methodological standpoint. The methods of their analysis look very similar. And they had a large patient population. They started with almost 1,000 people and extrapolated out between 300 and 400 in each one of their subgroups. So those things tell us that this study does meet the criteria that we should look for as we start to continue to have the conversation about pre-hospital blood in the US. I apologize by being by myself. There was no panelists to have some good discussion, but there are some very everyone's intelligent in the chat, but there are some very great blood program people in the chat. I would welcome you to put any feedback that you have in the chat to see. I want to pull up the question and answers just to see if we have any of those. Good question, Kevin. Do the authors look just at the patients with math transfusion after arrival for a mortality difference? They do, and I think we had that on a previous slide. I don't know if they looked specifically at mortality, but they did look at that massive transfusion. And so what they found was massive transfusion number and total number of blood products and didn't see a difference. So I'd have to look in the results to see. I don't remember reading a mortality difference for the patients that received a mass transfusion, but they may have. I'm sorry, Bill. I didn't even see you out there. Bill, what are your thoughts? Jump on and share.
Well, of course, I like the study. I particularly like your voice and how you handle it and everything. But this draws me to think future into the future. Do you Are we standardizing in at least in the U.S. with our blood programs? Is there a standard that we've developed? Let's call it the Utstein of blood transfusion. Have we come up with that standard so we can begin to look across the entire country about our blood program? So I'm demonstrating ignorance there regarding that, and I thought that would be interesting because again, this is not in ground, this isn't helicopter, and it's not U.S. Solely type thing. So I was just curious your thoughts on that, or if
I think
you've heard anything.
I think that's a great question. And there's some people in the chat. I see Brooke, I see Kevin, I see Joseph that run programs that do this, that do blood. So I will see what they think. If they think there's a standard blood product administration protocol out there, please drop it in the chat and add what you think is out there, and then we'll see what I think. We'll see what the experts have to say here. But I agree with Kevin in what you put in. Valuable study helps us look at feasibility for sure, in terms of distribution and shelf life. I would say that I don't think there's a standard protocol. Maybe we have some standard implement indications, but I think we're still working to see some standardization from state to state and agency to agency. Kevin says North Carolina is trying to get a standard program, but lots of variability nationally. I would agree 100%. Brooks is they've got a grant out to try and start doing blood. So again, I think lots of opportunity for us to maybe do some standardization and open to what folks, including yourself, Bill, have to say. But I don't know that we know exactly who the best patient is to receive blood yet. I think we're doing a lot of looking at giving it to a wide enough patient population that we then can develop some standardized tools to give it. So Jeremy said the same thing, especially in rural areas where whole blood is difficult. No national protocol, but multiple thoughts. I would agree, Jeremy. You can't open a trade journal or anything and see that without having some insights on variability and who's doing it. Joseph agrees. Most follow the military studies. I agree, and I think that's why we're seeing a lot of trauma victims getting blood. When lots of the evidence from our aeromedical units here in the U.S. would say there's a huge medical population of patients that could benefit from blood and have benefited from blood. So yeah. Kevin, I agree. Patients need to do a deeper dive on patients who get no blood after hospital arrival. That's a huge sample size that we need to look at. The patients who got it in the pre-hospital setting, but then didn't get any more in the hospital as a means to help us standardize who's getting it. There's definitely some patients there that are probably benefiting from it, but as we look at this being a limited resource, I couldn't agree more. So, and
Well, this is
Joseph, go ahead, Bill.
I was just saying, since we're at the since blood seems to be very promising, and I know there's some people that will jump up and down and say it's essential, and I'm fine with that. I do think this, though, is the time for us to standardize definitions, standardize the data that should be being collected. Otherwise, we're never going to get a good answer. And this may be the opportunity for the National Association of EMS Physicians and or a conglomerate of the larger organizations to help us reach this kind of thing. And then, of course, if it would spill over into the companies that provide electronic patient records. So I would encourage that we need this kind of thing so we have that ability to make sure, as you said earlier, it's the type of apples and that they're the same type of apples that we're comparing so we can get robust information about this, because we would hate for there to be some unintended consequence that we just can't see yet because we don't have the ability to measure it yet. And I do feel that rule still is probably the area that always gets shortchanged when it comes to anything, whether it be now or historically with an EMS.
Yeah, and I think too, Bill, as we talk about resources, right, our under-resourced systems, which oftentimes are our rural systems, maybe there's a different set of parameters or a different administration set. Maybe we do consider some of these, this study considered a standard treatment for places where logistically they give less blood because they have less patients and it's harder to maintain the blood supply. I will note too, Brooke put in the pre-hospital transfusion coalition. So there is a group that I think there's probably multiple consortiums, but there is a sort of national group that's tracking all the data and looking at all of this. I would say they probably don't have a standard definition yet, but at least there's a group that's collecting the data and looking into it to give us a means to move in that direction. But it's always nice too, at the end of the day, to know that we're not hurting anyone, and that at least in this study, that's what they demonstrated, and that probably there's more questions than answers, which is what all good research should tell us. So this sets the foundation again for some of our upcoming podcasts where we're going to take a deeper dive into some of the US studies that look at pre-hospital blood. And so hopefully this study drove us to some of those questions. That's my takeaway, which is any good research should drive us to ask more questions. And that's sort of why we picked this article. So it could drive us to ask more questions for some future research. But I want to say, Bill, what was any final takeaways, any thoughts, any additional thoughts that you had on this paper?
No, I I did appreciate it, and I like seeing the quality of the work that comes out and begins to tell us this does answer that interesting question that you said. What they result is that there doesn't appear to be a difference, and that could be beneficial in the big picture of things. So.
Yeah, I think anything that drives us to ask more sites is what we want. And Joseph said nearly 400 ground units as of June that are giving pre-hospital blood. So there's plenty of people asking these questions and looking for these answers. And I think that's exactly the conversation we want to be having. I do thank everyone for their feedback in the chat and for adding their comments. Joe, Kevin, Brooke, let's see, there were a couple other people that put their thoughts in. So appreciate everyone having their discussion, and Jeremy and Bill for joining me, for co-hosting with me so that we could have this great discussion. As a reminder, we do these every month. So we do have the educational podcast later this month. That is Friday, June 26th. And they'll be looking at an article that looks at preparing for death, dying, and bereavement care in paramedic students. So really interesting study there. And then next month for the clinical podcast, we'll be looking at pre-hospital and emergency care perspectives that have to do with pediatric care. So I think the title got caught out there, but we'll be looking at it, and we have the authors coming in from the pediatric hospitals system. There's a whole big group of researchers, and they'll be coming in and sharing their work there as we look to describe that. So please feel free to join us on both Friday, June 26th and July 13th. From Bill, Toon, and I, thank you very much for joining us for the Clinical Journal Club, and we wish you a great rest of your Monday.
We hope you have enjoyed and learned from this PCRF Journal Club. Please share it with other interested EMS professionals. An archive of past journal clubs can be found at pcrfpodcasts.org. You can also find us on Facebook at PCRF at UCLA and on our website, prehospitalcare.org. A special thank you to our sponsors, Limmer Education, providing educational tools for success at every stage of your EMS journey, and ESO, dedicated to improving community health and safety through the power of data.